We then had, in terms of university-based education, we managed to continue our clinical skills training, but some of our student year groups are 200 in size, and we then had to go from doing large-scale skills events to skills events of maybe just 6 students and a skills trainer for the social distancing, etc. We had lots of trouble with providing PPE, but we had to do pre-screening when they came into college. We worked in small groups. We had to have one-way flow through the buildings. We had lots of cleaning, so it slowed down everything. So what would have been a very quick skills training took many hours to achieve. I think to put a whole group of 200 students through, each student to receive 3 hours of clinical training took 15 days, full-time days, to get 200 students through 3 hours of training, 15 full days of clinical simulation to get that small groups through. But it was greatly appreciated by students, training them in PPE, donning and doffing, etc., infection control, patient assessment, and so on. In terms of academic work, the university introduced a no detriment policy, which said basically that any work that was done and came out badly during coronavirus for our normal students across the university, engineering and biology students and business students, they would basically not suffer because of the pandemic and disruption to their studies. But then we have a nursing council that says that certain things have to be achieved. So we had tension between what the regulator required and what the university was allowing. We then had the problem that because the students reduced their theory content by 60%, the university was saying, well, they haven't done enough for a degree. They haven't done enough study. So which bits haven't they done, and how are they going to catch this up? And because the university degree program is validated on study hours, and they basically weren't doing all the theory that they should have. So that was quite complex to resolve, how to protect the standards of a degree and the integrity of a degree program, but with less education. And then staff, because there was like a current that basically we could abandon education and just put people into practice, students into practice. There was a big fear from academics that this was a backward step, and all the gains we'd made in getting university level education was just being unpicked. And people were saying, you don't need a degree, you don't need to go to college, you can just go into practice and learn on the job, and that's all you need to do to become a nurse. So there was a lot of anxiety about staff, about some of the messages coming out from the health service, from government, about the quality or the benefit of education in universities. But we won the day. Okay. We then shifted to online delivery of theory, which was a mix of real-time and online sessions, anything from small groups of 6 up to lectures of 200 online. We made use of pre-recorded sessions that students could access at any time, and guided reading, and it's grown in complexity. And student engagement appears high. We actually get very, very good engagement, and students enjoy online learning. They can do it at their own pace, but they do miss the social aspects of coming into college to learn. That wasn't without problems. We have problems with digital literacy amongst our students, especially using multiple platforms to deliver and multiple ways of learning, online, real time, accessing recordings, uploading learning logs. So we had trouble with skills and digital literacy. We also had problems with digital poverty. So students didn't have computers, had poor internet connection, or the other big problem, because basically the UK shut down and everybody had to work from home, and all school education was delivered from home. We had students fighting for broadband, fighting for internet access, fighting to use the same equipment as their husbands, their wives, their kids. There was only one computer in the house, and everybody was trying to use it at the same time for jobs and study. Staff anxiety was really high. They felt overwhelmed because we went to a rapid shift within weeks from a face-to-face delivery to all online. So everything we delivered face-to-face were now delivered online. Growing concern over intellectual property rights, which seems quite a minor things, but staff were saying, well, if I'm recording all of my lectures and uploading them, why does the university need me anymore? Am I making myself redundant by uploading all of my lectures and everything? So we've had some big conversations about intellectual property rights and copyright. And then student motivation. Although some students were very engaged, we only heard from the engaged students, and there was a group who just completely disengaged. Very difficult to reach because they just wouldn't answer emails, wouldn't engage with online learning. And students miss the social aspects of coming to college. Okay. And then quickly at the end, a little bit about post-qualification education. Strangely, study leave was still largely honoured by employees. There was no blanket ban on study leave. So we still had qualified nurses doing their masters, continuing to attend classes and study online. But also we started running just-in-time training. So we started running a program for ward nurses to upskill them, to look after ventilated patients, to do respiratory assessments, to increase the capacity of the nursing workforce in terms of the numbers, but also the skill set. I personally I live in quite a rural part of Wales, and we have some quite small hospitals who are not used to looking after very sick patients. They aren't residential, but patients are in there for maybe 2-3 weeks, stroke rehabilitation, maybe rehabilitation after falls, etc. And there was a worry that they would start to receive much sicker patients than they used to. So I ran a program of upskilling in terms of patient assessment and critical care for ward nurses. So we did just-in-time training to the ward nurses and also physiotherapists, what Americans might know as respiratory therapists, so that they would be able to do a good patient assessment, communicate that, because quite often their medical backup was paramedics who would come out to patients in distress or family doctors. So we upskilled the ward nurses as well. So that's a very quick sort of gallop through of what we've been through as a College of Nursing in maintaining our students. What next? Well, we've got students who are, in theory, at the same point in their nurse training, but with very, very different experiences. Some have missed a lot of clinical hours, some have lost a lot of theory hours, but we know that to get registered, they still need to have a regulated program. So we've got a lot of mopping up to do and a lot of alterations in programs to make sure that the students who've contributed massively to the national effort for coronavirus are not disadvantaged, that they still qualify on time, on date, and can join the workforce as colleagues. So that's it for me. I'll stop sharing, and then I can take some questions at the end.